Thank you very much. Hi, everyone. Thank you to the organizing committee for having me. It's a great honor and pleasure to be with you at this annual meeting. Thank you also for the King Faisal Research Institute for the logistical aspects of me coming here. And before I start as well, I want to send warm greetings to my former Saudi fellows at the Division of Hematology at the University of Ottawa. We're very fortunate to welcome every year a few of your younger colleagues, and it's always an amazing experience to have them with us for a year or two, and I hope they're doing well, and I hope I will meet some of them, and really thank you for your trust again in our ability to train them during their stay with us. So these are my disclosures, and what I wanted to do today was just briefly review the epidemiology and the current evidence around prevention of thrombosis in acutely ill medical patients, identify some of the knowledge gaps, and then discuss the results of a ongoing project about using real-world evidence to further improve the knowledge around the prevention of VTE in medical patients. This is just to show that's where I used to live before moving to Canada, in Brittany, France, and because it was such like the tip of the nose of France, right? And it was a region where, surrounded by the sea, so it was very easy for us to do epidemiological studies because patients couldn't escape elsewhere to be diagnosed with their VTE. So it was easy to capture all the cases around, so during repeated years. So we did the exercise in 1998, 2006, 2013, and showing that overall there is a slight reduction over time in the incidence of VTE, but certainly not no reduction in the risk of VTE. But what we did as well in one of these exercises was to try to get a better sense of where these patients were coming from and how many of these venous thromboembolism could we attribute to a stay in hospital. So during one of these years, we had a total of 458 new diagnoses of VTE, and what was very interesting was that obviously the vast majority of them were diagnosed with VTE as outpatients, and only a few, maybe 10, 15% of them were patients who were inpatients at the time of the diagnosis of their VTE, and a few others were from a long-term care institution. But what was very interesting was that when you would ask outpatients whether they had a recent admission to hospital, answer was yes in 92 patients, meaning that a total of over a third of all the VTEs that we diagnosed in the entire province during this year were related to a hospital stay. And interestingly, the majority of them were diagnosed not during their hospital stay, but after they had gone home. So it really shows us that not only we still see a lot of cases of VTE related to hospital stay, but that many of them are diagnosed after the patient is back home. And that begs the question of what to do to prevent VTE after discharge from hospital. The main tool we have to prevent VTE is low molecular weight heparin. These are all clinical trials consistently showing a 50 to 60% reduction in the risk of VTE when using a low molecular weight heparin versus placebo at the expense of an only minimal non-significant increase in the risk of major bleeding. And actually, if you synthesize the evidence around that, the studies consistently show, including a reduction in the risk, 60% reduction in the risk of fatal PE when you use thromboprophylaxis in medical patients without a significant increase in the risk of major bleeding. Why don't we use DOACs in that indication? We discussed DOACs before. Well, so two large clinical trials have been made trying to use DOACs for prevention of thrombosis in medical patients. The two of them actually failed. The trial using apixaban did not meet their non-inferiority margin, meaning that you could not exclude that it was doing actually less well than enoxaparin. And there was also a trial using rivaroxaban in this indication, but that one failed for a significant increase in the risk of major bleeding, when using rivaroxaban rather than enoxaparin. So with all this data, current guidelines certainly recommend that in patients at increased risk of thrombosis, we use thromboprophylaxis, mostly using heparins, either low molecular weight heparin or low-dose unfractionated heparin, but that in those with either a low risk of thrombosis or a high risk of bleeding, we would rather not do that. And that becomes tricky then, because it means that we need to be able to determine who are these high risk of thrombosis patients who can clearly derive benefit from thromboprophylaxis and who is at risk of bleeding as well. And through the years, we've seen many clinical decision rules being proposed with various levels of validation, but they are often a bit complex based on non-standardized criteria. And I must say as well that all were derived at the time where we were already using low molecular weight heparin. So we don't have a perfect, we're using the PADUA, we're using the improved risk score, but none of them are really perfect in terms of assessing these risks. And maybe as a result of that, for many years now, we know that all over the planet, in fact, although the upper part of the graph shows you the proportion of patients deemed at high risk of VTE when they are admitted to hospital, and the lower part of the graph shows which proportion of these patients were actually receiving thromboprophylaxis during their stay. And as you can see, consistently, half of medical patients are high risk of thrombosis, yet only a limited proportion of them do receive thromboprophylaxis when they are admitted. So we clearly need to do a better job at identifying high-risk patients and proposing them thromboprophylaxis. How can we do that? Well, we know that likely what works best is to implement some alerts, either electronic alerts or human alert in the patient's chart. So as soon as a patient meets the criteria for prophylaxis, either the electronic medical record would trigger a pop-up or a message to the physician saying, hey, be careful, that patient has some high-risk feature, or having a pharmacist or a trained nurse reviewing the chart and identifying those patients. And this has actually been shown to be effective at preventing the actual risk of VTE. And then, as I was alluding to before, the issue is that despite that, some patients will still be able to develop a blood clot, including after they went back home. And this is a conceptual slide showing that actually that's the majority of them. And this begs the question of what to do when the patient goes home, particularly in the context of length of stay being shorter and shorter as time goes, right? The current average length of stay for most medical diagnoses might be 4 or 5 days in hospital. And that's tricky because the clinical trials that validated the use of low molecular weight heparin actually tested 10 days or 6 to 14 days. So when you send a patient home before a week, say, then what to do? Because you didn't give kind of the minimal duration of thromboprophylaxis that was ever tested. So again, there we likely have a gap where we should be able to do a better job at finding some of them who are still at risk of thrombosis when they go home and maybe should go home on something. And actually, so far, clinical trials in that regards have been quite disappointing, showing a reduction in the risk of VTE when you do use thromboprophylaxis after hospital discharge, but at the cost of a significant increase in the risk of major bleeding when you do that. So that points out again towards risk stratification and how to best identify those patients at risk of clotting, maybe with a lower risk of bleeding, that could benefit from being on extended thromboprophylaxis beyond their hospital stay. But until we have that, clearly the clinical guidelines do not recommend using extended thromboprophylaxis in medical patients. I like the last one from the NICE who points out to an interesting question again, that one of patients who go home very early in their stay, and the NICE guidelines say, well, maybe in these patients we need to consider keeping them on a low molecular weight heparin for at least 7 days, even if they go home before day 7. So in the last part of the talk, I want to present that ongoing project that we have about using real-world evidence to try to better understand risk stratification. And I want to acknowledge here the contribution of Dr. Uwaida, our scientific committee chairman here, who has been part of this group with other distinguished colleagues from around the world. And so what we've been trying to do is to try to understand heterogeneity among patients and work towards an individualized approach to VTE thromboprophylaxis. So the first step of that project was to describe risk of VTE and major bleeding in those patients receiving thromboprophylaxis, and also try to see if we could identify some risk factors for VTE and for major bleeding, describing also the duration of thromboprophylaxis. So we're using a large database from the US, the Optum database. It's a de-identified database where we have all information about comorbidities, concomitant medications, blood work results, and so on and so on. So what we did is that we took patients older than 40 who had one of these 6 diagnoses listed here on the left, but who did not have any of the exclusion criteria here on the right. So we didn't want patients with a just recent VT or major bleed, patients who just had a major surgery or who did require full dose anticoagulant therapy, those with AFib, because obviously they would be anticoagulated as well. And we also excluded patients with severe kidney disease. Primary endpoint was symptomatic VTE, and we were also collecting major bleeding as a safety endpoint. These are the definitions, and we use some survival analysis to run the analysis on this project. So as you can see, the initial database was more than 5 million patients. Of them, 640,000 were without any of the exclusion criteria and had been using low molecular weight heparin during their stay in hospital. Eventually, after excluding either the ones who did not have enough data in the database to be able to run the analysis, and that was a big chunk of the patients because we wanted to have info on them for at least 1 year preceding their entry in the database, and then excluded the ones on anticoagulants or the ones younger than 40. At the end of the day, our final cohort here was 123,000 patients. These are the baseline characteristics of the patients, and on the middle you find most of their diagnosis, and you can see that up to 20% had a history of cancer. Some of them had a history of ischemic stroke, and on the right side you find also their previous history of VTE for some of them, previous history of major bleeding, but again these were not recent events, these were events in the past. The age distribution and BMI as well. So this is the distribution among the 6 diagnoses that we were interested in. The majority of patients were admitted for infection, and then came respiratory insufficiency, and less people had either cancer, ischemic stroke, inflammatory conditions, or heart failure. That's a very interesting slide to me, and it's actually looking at how many days of enoxaparin did this patient receive. And as you can see, very soon after their admission, well, a lot of people are either the thromboprophylaxis is discontinued, or they go home and the thromboprophylaxis is stopped. So when you look at, again, which proportion of patients received that minimum 7 days of thromboprophylaxis that was tested in clinical trials, it's only maybe 20% of them. And most people will have their thromboprophylaxis discontinued after only 4 or 5 days. And post-discharge, that's another interesting information as well, only 2% of patients went home on thromboprophylaxis. So it shows that actually in line with the guidelines that I've shown you before, only a very small proportion of patients would be on extended thromboprophylaxis beyond their stay. This is a main result of the study, showing that overall at day 90 following admission, up to 3.5% of patients will have developed a VTE. while 2.2% of them will have developed a major bleeding. So again, showing that rather tight risk-benefit balance, where definitely a significant number of patients will develop a VTE following their hospital discharge, but some of them also have some major bleeding, despite the fact that, again, only a very small number of them were receiving anticoagulant therapy when they went home. And that's very interesting finding from this data is that the risk of both VTE and of major bleeding is actually highly variable depending on the indication for the admission to hospital. You can see right away on the right top corner there that cancer patients behave very, very differently, with a risk of VTEs that was double the one seen in the global cohort, 7%, and a risk of major bleeding that was also slightly higher than in the other population. On the opposite, patients with ischemic stroke at the left bottom part of the graph were the only group in which the risk of major bleeding was actually higher than their risk of having a VTE post-discharge. So you can see that, you know, not all patients are equal, and definitely the risk of VTE and of bleeding varies quite a lot depending on why are patients admitted to the hospital. And this is again the end of that first step, where we went on then to look at all the risk factors that could help us predict the risk. Here are shown all the ones that were significantly associated with a higher risk of VTE on the left, higher risk of major bleeding on the two subsequent columns. And nothing really surprising there. You know, patients with cancer again, patients with a previous VTE, those with thrombophilia, have a higher risk of developing VTE, while the ones who were admitted for a stroke, the ones who had cancer, or the ones who had a history of previous bleed had a much higher risk of bleeding. And I can let you appreciate here the list of the other risk factors that were found associated with an increase in these risks. So moving forward, we will certainly keep working on that database now, again to try to see if we can find a group of patients where thromboprophylaxis could be of benefit, particularly when they go home. So as a conclusion, substantial heterogeneity in both the risk of VTE and of major bleeding in patients admitted for acute medical illness despite thromboprophylaxis. And I think we clearly need better risk stratification to help identifying and help setting up optimal strategies for prophylaxis in this population. We were very fortunate or very lucky to be able to identify several risk factors that are able to prognosticate increase in this risk. So again, the next step out is to keep working on that now and to try to improve our strategy. And with that, I would thank you for your attention, and we'll be happy to take any questions in the Q&A session as well. Thank you.